Let me know when we're online.
Yes, sir. You can start.
We're on?
Yes, sir, we can start.
Awesome. Good morning, everyone. This is Dr. Harish Sampath Kumar. I'm one of the founders of JH Rehabilitation. I welcome you all to day 4 of the post-COVID rehab webinar series. The topic for today is overview of impairments noted in post-COVID rehab, benefits of early intervention, and role of physiatrists. So, as we all know, the number of cases in India continue to rise. At the same time, the need to open the economy is also imminent, and we have opened up a lot of our economy, and we don't see any promising treatments in the near future. Because of this, there will be a need. As the cases continues to rise, there will be a need for rehab professionals to play an important role in improving these patients' quality of life. And that is the reason we've been doing this seminar. So as rehab professionals, we could understand what is the up-to-date, what is the current evidence on these treatments and how we can best provide our services to these patients. The speaker that we have for today is Dr. Miguel Escalon. Dr. Escalon is the Vice Chair of the Department of Rehabilitation and Human Performance. He came to the Icahn School of Medicine at Mount Sinai in 2013 and has served as a Director of Critical Care Rehabilitation since 2014 and as the Residency Program Director for the PMNR Residency since 2017. He's an Associate Professor in the Department of Rehabilitation and Human Performance and the Department of Medical Education at the Icahn School of Medicine at Mount Sinai. He received his undergraduate degree from the University of Chicago and his medical degree from University of Illinois. He received specialty training in physical medicine and rehabilitation at the Baylor, UT, Houston, PMNR Alliance. Dr. Escalon is both certified in physical medicine and rehabilitation, spinal cord injury medicine, and brain injury medicine. He works closely with physical therapists, occupational therapists, speech-language pathologists, neuropsychologists, recreational therapists, and other medical and surgical specialties in order to provide a comprehensive care to this population. He also oversees the rehabilitation and mobilization of critically ill patients, especially those in the ICU. The scope of his ICU practice includes debility, critical illness, myopathy, polyneuropathy, pain, spasticity, delirium, early mobilization, etc. He also focuses on neurorehabilitation of any disease that affects the central nervous system, brain, or spinal cord. He is an expert in spasticity management, including intrathecal baclofen pump management and botulinum toxin injections. Dr. Escalon, unfortunately, could not join us directly for the presentation today. However, he has recorded his video, and he would be available once the recorded video is done to answer questions live. So the recorded presentation is going to be for 45 minutes. And at the end of the presentation, Dr. Escalon will be available to take questions. As most of you may know this already, this is a YouTube channel. So there is a chat section on the right-hand corner of your window of the YouTube channel. You can post your questions there. You can post your questions throughout the presentation. And at the end of the presentation, I will present the questions to Dr. Escalon, and we will answer them. Without any further delay, I think we can go ahead and start the presentation. Srividya, is everything okay?
Yes, sir, just a second. It's getting attached.
We apologize for the delay. I think it should be up and about soon. Srividya, the audio is not clear.
See in the studies that brings things can lead to really long-term issues. So early intervention is really our key. Anecdotally, we're seeing that patients with COVID in the ICU are more likely to be stable either iatrogenic or just to a degree they're ill.
Okay, sir. Because okay, no, I'll continue playing. Let me check and I'll get back to you, sir.
Making it difficult to do any mobilization. They higher FiO2, they have extremely high levels of delirium. Now, generally speaking, there are a lot of issues with bed rest, but these patients may be having more bed rest than the patients we've seen before. So the cardiovascular system goes through a lot of changes just before bed rest, tachycardia, decreased lung function, stasis, and you're trying to get these patients up after weeks of bed rest, they might have all of these issues. We talk about just muscle wasting as well. So a healthy person can lose 7 to 10% of muscle. This particular study compared 63 persons and followed ultrasound measurements of the quadriceps cross-sectional area, quadriceps over duration in the ICU. And what they found was from day 1 to 10, day 10, the mean reduction in muscle is 18%. So what happens is you become weak, then you live on purpose. So you become weak, and you can't get up. So then you are on prolonged bed rest. And that is kind of borne out here in this figure. And we see that single organ failure people, single organ failure, less muscle mass. But those are multi organ failure, which many people who go and have kidney injuries, strokes, different things. There's a lot of muscle mass. So basically, I see results in a lot of stress syndrome area is relatively similar. We could compare. And the goal of this was just to determine which variables to
We are really sorry for the inconvenience. We got a news that the audio is a little low, so we'll try replaying it again. So just sorry for the inconvenience. Just wait for 5 more minutes. We'll replay it again.
I am Physiatrist at Mount Sinai in New York. I'm here to talk to you today about rehab considerations in patients with COVID.
Yes.
Nothing to disclose. So we're going to talk about 3 kinds of levels of things. One would be rehab care in the ICU or the acute hospital. The next is acute inpatient rehab. And finally, we'll touch briefly on wellness of staff, mental health of staff. So rehab care in the ICU will break down into 4 topics. One is we'll kind of review quickly and briefly post-intensive care syndrome, what it is, what it looks like, medical management, therapy considerations, and long-term implications. So post-intensive care syndrome is basically some deficit in a cognitive, physical, emotional domain. And as we'll see in the studies that we'll present briefly, can lead to really long-term issues. So early interventions really are key. Anecdotally, we're seeing that patients with COVID in the ICU are more likely to be sedated, either iatrogenically or just to the degree that they're ill. They're often prone, making it difficult to do any mobilization. They need higher FiO2, and they have extremely high levels of delirium. Now, generally speaking, there are a lot of issues with bed rest, but say these patients maybe have even more bed rest than other patients we've seen before. So the cardiovascular system goes through a lot of changes, just to use one example, from bed rest. So we're talking about tachycardia, decreased lung function, orthostasis, and when we try to get these patients up after weeks of bed rest, they might have all of these issues. So something to keep in mind. And we talk about just muscle wasting as well. So a healthy person can lose 7 to 10% of muscle in a week. This particular study compared 63 persons, and they followed ultrasound measurements of the quadriceps, cross-sectional area of the quadriceps over duration in the ICU. And what they found was from day 1 to day 10, a mean reduction in muscle mass of 18%. So what happens is you become weak, or you put on bed rest. So you become weak and you can't get up. So then you are on prolonged bed rest. And that is kind of borne out here in this figure. And we see that single organ failure, people with single organ failure can tend to lose less muscle mass. But those with multi-organ failure, of which many people with COVID have acute kidney injuries, strokes, different things, they really lose a lot of muscle mass quickly. So basically, ICU-associated weakness, or PIC syndrome, results in a lot of long-term outcomes. This is a study of 222 patients, not COVID, but had acute respiratory distress syndrome, or ARDS, something relatively similar we could compare. And the goal of this was just to determine which variables during an ICU stay were associated with ICU-associated weakness, and those patients that developed this weakness, which was only defined as a manual muscle test score of less than 4. So not that bad. Kind of find out how those patients did. So what we see is, and something to keep in mind is, this is over 2 years. So the dark line is people without ICU-associated weakness, so people that maintain their strength. And the dotted line is people that had ICU-associated weakness. And you see there are statistically significant differences 2 years out in hand grip, physical function, 6-minute walk distance, and maximum inspiratory effort. So we're talking about prolonged, protracted issues here. And they did all these analyses, and basically there were 2 factors associated with development of ICU-associated weakness. One is age, can't do anything about that. The other was duration of bed rest. We could do something about that. So normally, the treatment would be easy. We would say, okay, these people with COVID, just mobilize them sooner, things will be better. But the problem is, and here this slide is showing you the absolute contraindications for early mobilization in the ICU. These are Mount Sinai's guidelines. And you see the 4th highlighted one here is prone positioning. And so there are a lot of issues here. A lot of these patients require prone positioning and won't be mobilized at all. But we also have limitations in getting people out of bed. So one thing is to mobilize them. Another thing is to kind of get them from bed to chair and things like that. So some of these patients are going to have a high FiO2 requirements with low O2 saturation. Some of them are going to be on the high frequency oscillatory ventilation. Some of them are going to be really sedated with a RASS score of less than -2. What can you do with someone like that? By definition, they get prolonged bed rest. And these are the things that we're seeing in patients that have COVID. So we should proceed. So early mobilization in COVID-19. So we should proceed as we would with any other diagnosis as much as we can. So we want to mobilize them early, get occupational therapy in there, neuropsychology if you have it, and work on these things as best we can. But the problem is all these things we've been talking about, the delirium, the prone positioning, the sedation, and the up and down course. A lot of stories of people getting extubated and reintubated and downgraded from the ICU only to be, or upgraded from the ICU only to be downgraded back to it. So the long-term implications of this are such that we cannot mobilize yet. As of yet, we've not found a way for people with severe COVID to be mobilized in the ICU. So the presumption is these patients will develop ICU-associated weakness and prolonged, protracted functional, cognitive, social issues that will need long-term care. Something we have to keep in mind. So let's talk more about inpatient rehab. So we're going to touch base about PPE, who can we admit safely, how do we make this work, what are the complications we may look out for, and a little bit about some outcomes from Mount Sinai. So PPE is personal protective equipment. There's been a lot of research studies now shows the N95 respirator is what we should be using with patients that have active COVID infection. So there are different kinds. There's also a Duckville kind. If you look in the corner, I have this Duckville N95, which is a little different. It's very important to get fitted for your mask. So you have to wear the right size mask. This is a box of smalls. Smalls are sometimes harder to come by than regular. You need to know what size is appropriate for you so you can get the right mask. Then you should be wearing a gown, gloves, booties, and headgear. And also you should be wearing some form of face mask or goggles. If you look back up in the corner, I have my little goggles here. There are also face masks that can be used. And I also have the other kind of N95 here in case you want to see it. So just like in that picture. So it's important to be prepared to see patients that have active infections. Some of you may be seeing them on consults, at outpatient, acute, or even on your acute inpatient rehab unit. So one thing to kind of think about is I like this picture because it's split. So the picture on your right or the person's left is someone that is dressed to go see someone that has an active COVID infection, basically, or if you're going to do an aerosolized procedure. Person on the right has less PPE. You know, this is how we might dress in someone that has that used to have a COVID infection, right? So we may or just with any patient now. So we're at Mount Sinai, we wear a regular face mask for anyone that we see, and I wear goggles for every single patient. I don't gown up for every patient, only for those that are on isolation for some other reason. But basically, the standard of care is a surgical mask and goggles. If somebody has COVID, then you need to wear an N95 and goggles and the full protective gear. It's important to note, that this gear is contaminated, so you shouldn't take it home. If you are seeing patients with active COVID, you should change out of your work clothes before you go home so as not to infect anyone in your home. Your shoes are particularly important there because people often forget about that. So you should probably have a pair of work shoes and a pair of home shoes. So we talk about admission criteria to an acute inpatient rehab unit. What do? A lot of that has to do with how your unit is laid out. Do you have one floor? Do you have two floors? Is it a straight hallway? Or is it an L or U shape? And also, what can your rehab unit handle? Do you have oxygen abilities on your rehab unit? Lab work? Can you do, different kinds of chest x-rays, whatever would be needed? So these are things to kind of consider. And we're going to get more into detail about these things too. So when we talk about acute inpatient rehab criteria, we got to think about what patients are we going to take? Are you going to take patients with active COVID? That's something really to think about. So people with active COVID are very sick. Some of them, if you take them with active COVID, you will have patients get sicker and have to transfer off, require more oxygen, potentially code, potentially die. Something to keep in mind. That's very different than post-COVID, meaning having gone through COVID and now we're on the other end, but someone that's actively ill. So one thing to keep in mind also is, how do you keep the unit safe for everyone? So one thing, and you'll see this picture here in the bottom right corner, there's a yellow line. One thing that happened at Mount Sinai, and I think other places, is we developed zones. So on other units that were seeing active COVID, we never did on our acute rehab unit. When it functioned as an acute rehab unit, we've only accepted post-COVID patients. But we have worked on acute COVID units with our rehab doctors and around the hospital. So basically we'd put tape on the ground and we would tape off areas. If an area was taped off red, that meant you could only go in that area if you had full protective gear, because that was an area that had potential COVID there. So you say if you were walking in a patient room, outside that room, there'd be maybe some red kind of square, so that when you stepped into that square before you walked in the room, you had to be in full protective gear. And then depending on the layout of the unit, you might have larger or smaller red areas. And there were yellow areas. These were areas where you as a practitioner, based on how you felt, could choose to be in full protective gear, goggles, N95, all that, or not. You might walk by somebody that's in the full protective gear, so you'd have to keep that in mind because they may have just come out of a room. But it was kind of your choice. And then there were separate green areas that were strictly PPE, full PPE free zone. So you weren't supposed to be in your gown there, or if you were wearing booties, and those things you would take off. You could keep your N95 and your goggles on, but you weren't tracking kind of the virus around, so to speak. So that's kind of what we did. And it is important to think about those things. So if you split your unit up, say you have an L-shaped unit and the gym is in the middle, right? One wing is COVID and the other wing is not, or post-COVID. Are these patients going to go to the gym, or are they going to stay in their room? If they go to the gym, how are they supposed to work on equipment, etc.? So things to consider when we talk about that stuff. So if you're going to accept acute active COVID, and you don't have a way to separate by floors, or these patients don't have their own gym, then they may have to stay in their own room. You could take people with active COVID to the gym if that's the only, if you have only COVID patients, but then the whole gym becomes a red area. So everyone that's in the gym, all the therapists, etc., basically have to work in full PPE all day. You really have to consider that because it's hot. It's hard to breathe for a long period of time. People get skin breakdown on the nose. They just become uncomfortable. So something to think about. I know that there were other rehab facilities in the New York City area that even with post-COVID patients, initially, they could only do rehab in their room. But there are a lot of things to kind of think about if you're going to share the unit between the two. Just want to bring that out there and have everyone kind of be aware that these things are things we have to think about. So what happens if you open your rehab unit and your hospital, say, can't test for COVID, or the test takes forever? Or if you're worried about a patient on the unit that has COVID, maybe could have COVID, they lose their sense of smell. And you say, all right, well, what's going on here? So all of this depends on your hospital system. But basically, if you're going to accept a patient to your acute rehab unit and you have no idea whether they have COVID because of any reason, you have to quarantine them. This is if you have no way to test either, and you have no way to test. You have to quarantine them for 14 days. So they would stay in their room. You could have equipment in their room. They could do the therapy in their room. The therapist would have to go in full PPE gear. They would be a quote unquote red zone until that time passed and they were symptom free. And then you could open them up. Or, you could test them. You could require tests before someone comes in. At Mount Sinai, what we do is if someone's coming from another hospital system, we require a test, negative COVID test within 2 days of admission. And even sometimes for people that are coming within Mount Sinai, we might require a test in special situations. Sometimes we don't, depending on patient, how long they've been in the hospital, their exposure, etc. And then what do you do with a patient if you think maybe patient might be developing COVID while on the unit? So obviously, it's similar. So if you have the ability to test, you send a test right away. While you're waiting on those test results, no matter the situation, you have to assume that patient has COVID. So you have to then gown up, N95, goggles, the whole deal. And you have to do that until you get a negative result. So depending on what that time is, a few hours or a few days, that person will be red zoned. If the test comes back negative, great. If it comes back positive, you need to have an idea what you're going to do with that person. If your unit is not meant for people that are COVID positive actively, you have to have some kind of plan. Can I transfer this person here or there? Or do I have a deal with a hospital or another unit where they will take my patient? So that pre-planning is important. If you don't have a way to test and you're taking both patients or you're going to wait and see, then you have to quarantine them for 14 days and wait and see. We talked a little bit about what can your unit handle? What resources do you have? Do you have enough staffing? Say all of a sudden, or equipment, say all of a sudden you have to test, you have 10 patients, you have to test 6 of them for COVID because what visitor came in and that happened to be COVID positive, now you got to test everyone. So then what do? Do you have enough PPE for all of that? Enough N95s, oxygen, staffing of nurses, all these things. So something to really consider in your acute rehab unit is your resources, not just your numbers, but especially in terms of people, like their stamina and ability to keep up like a very intense level of care for X amount of time. Now I just mentioned visiting a second ago. So just to talk a little bit about how it was at Mount Sinai, and I think I mentioned this when we spoke a few months back, but in the peak, at the peak of COVID, we were seeing 5,000 new cases in the hospital a day. Insane numbers. The hospital pretty much shut down to anyone that was not COVID. We had beds in the cafeteria. Our gym was converted to beds for COVID people with COVID. Our rehab units were taken over, became medicine floors. We had beds in Central Park. It was crazy. During that time, there were 0 visitors allowed to the hospital. Now things have normalized a bit. Our rehab units are back open. We have rehab patients. People have to be screened. So if you have a visitor coming in, they have to be screened at the entrance to the hospital. They get their temperature checked with a little temperature thermometer gun or whatever. They get asked lots of questions, so they're screened. They come up to the unit. They're only allowed to stay a few hours. They have to go. This does present an issue in acute inpatient rehab because we do a lot of family training, especially if you're talking about people with severe neurologic injuries, stroke, traumatic brain injury, spinal cord injury. A lot of times it's family training. We really have to plan that. You know, it used to be family could come to the gym whenever, but now we can only take so many people in the gym at a time. And this is another consideration I forgot to touch on earlier. Social distancing and spacing. In the gym, you can't have people on top of each other. So planning who goes to therapy during what time and how many therapists can be in there at a time, you know, really depends on how many square feet you have and how much you're able to separate people. So when you add people for family training, that has to be taken into account. Do we have enough space for family training to happen or not? So that has to be pre-planned, and the therapists work together to make that happen. It still happens, but unfortunately it has to be planned, like I said, and it's usually done in less sessions. It's compressed. But it's what we have to do to get everything done. Hopefully things will change soon, but just to give you an idea of something that has worked for us. So in acute rehab, and these are things that some of them obviously start before they come to you. These are things that we're seeing anecdotally. Again, there's not a lot of great data out there. I think there's maybe 1.5 papers that have any true rehab data on COVID. And even those are small numbers. But anecdotally, these are the things we're seeing. We hinted at this with the ICU bit we talked about earlier. So we're seeing a lot of critical illness, myopathy, polyneuropathy, what we'd call PIC syndrome. People that are so debilitated that otherwise before COVID had nothing wrong with them, now cannot lift their arms or legs. Extremely weak. Prolonged hospital course, prolonged acute rehab course, oftentimes go home with needs for equipment. They might need a wheelchair, even temporarily, or other DME. They have prolonged, protracted, sometimes on the order of years, recovery. And that's not just physical. We talk about the cognitive too. That's one thing to consider. And those effects are compounded. If you have a patient with, say, tetraplegia that gets COVID, is on bed rest, all these things we talked about, the debility is even more apparent. And imagine having a spinal cord injury and getting COVID and then getting a cognitive deficit from COVID. That's devastating functionally and to your independence. Or say, one of the medical complications we see here a lot from patients being laid prone are brachial plexopathies. What happens if you're a stroke patient and you were ambulatory, your right side is strong, your left side is weak, then you get a right upper extremity, right arm brachial plexopathy. Then what? Functionally, what happens to you? So depending on the person's history, the resulting effects of the complication can be very different. So things to keep in mind. Lots of pain we see, lots of pressure injuries, especially sternal because of prone positioning, but also a lot of the traditional ones, occiput, sacral, ischial, you name it, we've seen it just from the prolonged bed rest and the ventilator needs. Even we've seen sores around the mouth and degradation of the trachea or into the esophagus with an NG tube and things like that. So a lot of things to keep in mind. Anecdotally, we're seeing a lot of dysautonomia in people that have had mild COVID. So maybe people that never had to go into the hospital, or if they did, they didn't go to the ICU. We're seeing a lot of tachycardia, dizziness, nausea, cognitive fatigue, a lot of things that actually would mimic, we call dysautonomia, but might mimic like post-concussive syndrome. We're seeing that a lot. And something to keep in mind when we talk about treating people with COVID. ADLs and IADLs are a huge consideration. Obviously, these medical complications I've hinted at could really affect activities of daily living or kind of other ways that you're independent in terms of making correct change and doing cooking tasks and things like that. Psychiatry is a big one we've not mentioned. There's a lot of PTSD type syndromes that can happen with COVID, insomnia, depression, and survivor's guilt. So there's been reports of entire families, 10, 12 people getting COVID, 3/4 of them unfortunately die. the 1/4 that's alive, survivor's guilt, difficulty in moving forward and pushing along. And these are things that make sense. Why did I survive versus my brother or my sister or my mother or my father, or PTSD? And that's been well documented with any kind of ICU stay. But we have to be aware of those things so we can treat them as best we're able, so they don't prevent somebody's progress in acute inpatient or outpatient rehab. So referrals to psychiatry, medications for depression or PTSD. Same for cognition. Somebody that has debility otherwise, you may do PT and OT for, mostly physical type things, but maybe OT, speech, neuropsychology become involved for cognitive assessment, evaluation, and treatment. You might consider using something like amantadine or Ritalin, where in other times you might not. And I've done that, and to decent effect at times. And I think that, there's been documented kind of neuroinvasion. This is large vessel stroke paper that came out also in COVID, and some sense as to why maybe there's so much cognitive deficits. We talk about the different receptors, and but we're not going to get into all the kind of medical depth right now. But there's been documented strokes, increased frequency of stroke and risk of stroke, COVID, and also DVTs, clotting is a big thing. So things to keep in mind. DVT prophylaxis is important, monitoring for stroke and changes, and just keeping an open understanding of what could happen. So how do we interpret this for the long term? What do we need to get ready for? So there may be a surge in need for nursing home or subacute rehab or skilled nursing facility care, especially people that develop the debility and PICS that maybe live alone or don't have home care in the same way they otherwise would because their family has to work. Maybe they live in a building with stairs. There's no way to get them up and down. Nursing homes have their own problem. There were a lot of stories, at least here in the United States, that many people in nursing homes died of COVID. So patients may be wary of going to a nursing home or a subacute or similar, but there may not be other options for them unless you're able to keep them indefinitely or for many months. The need for home care will increase for the same reasons I mentioned. You may want someone to go home, but they need help cooking, cleaning, getting in and out of the bathtub. So you need trained professionals for home care. Something very important to keep in mind. Outpatient PT and OT. When do you reopen it and how do you reopen it? So initially we reopened virtual PT and OT and speech. And so that happened kind of in May. And over time, we were able to open outpatient therapies. Right now, outpatient neuropsychology, outpatient PT, OT, and speech are all open. But they're regimented and scheduled very specifically. So there are only so many patients that can be in our outpatient gym at a time. And the other consideration is how many people can be in your waiting room. Perhaps you work somewhere that has a large waiting room, but in New York, our waiting rooms are small. So, and this has happened not just with outpatient PT and OT, but also my outpatient practice, where I can only schedule so many people in person at a time. First, they have to be screened when they come in. Second, only so many people can use the elevator to come up to my floor. Third, we can only have so many people in our waiting room safely. And then fourth, in between when patients see me, we do a thorough clean of the room. So things move slower. So kind of what we've done as a department is say we see one patient in person, and then as the cleanup is happening, as the other person's coming upstairs and getting to the waiting room, maybe we do a virtual visit and we sandwich things like that. We still are trying to keep in-person visits to those who really, really need, but slowly over time we're opening it up more. There are things that might be more amenable, services I should say, might be more amenable to video visits. You know, if you're in treatment with neuropsychology, maybe that, or especially if it's something more like adjustment disorder as opposed to cognition, where you might need to be doing tasks with the neuropsychologist. And so there are a lot of considerations. At first, when I opened my practice, it was primarily just for people that needed injections, and we shied away from anyone else. But slowly, we're kind of opening up. So I'm happy to take anyone's questions after the talk about this, or you could email me separately. But I just wanted to kind of lay some things out there for you. One thing we did see was home care workers, therapists, different people that did not feel comfortable working or got sick themselves. So despite us needing a surge in the following services, or the listed services, our workforce was the same or smaller. So something to keep in mind when planning. Now let's talk about, we're going to take 1 month of acute inpatient rehab. Again, what I want to mention is the data that we're presenting is people that had COVID, but when they came to the acute rehab unit, were deemed to be post-COVID, meaning they no longer had active medical issues that were worrisome. Some of them actually had a negative COVID test at the time. Others had prolonged stays such that the assumption was made, say 14 days or whatever, that they didn't have active COVID anymore. So, but most of the patients we're going to talk about had a negative COVID test, positive COVID antibodies, right, or a previous positive COVID test. So these are all patients with diagnosed COVID. This is the month of June, so this is kind of the first full month we were open. We opened in May for acute rehab, but it wasn't a full month. So this is the first full month we had. And we have more data kind of building, but I wanted to share this with you. So the first 20 patients we had, the majority were male. There's no statistical significance data run on this. These are just descriptive stats. The age was a range of 40 years to 72. So we had a wide range. We didn't have anyone younger than 40, but 40 is pretty young for somebody to come to acute rehab. Our average age was in the 60s, and you see the standard deviation there. So it is a quote-unquote older population when you look at it from the eyes of a 20-year-old. But really, nowadays, being 40, 50, 60 years old, people are very active, still working. And so it's a lot of patients that were working and very active. So this isn't a group of people that are, octogenarians or anything. The racial ethnic breakdown is as follows. 4 persons were white, 6 Hispanic by ethnicity, 6 Black, 3 Asian, and 1 other. Other meaning either they the patient listed other themselves, or we're not sure. So we put them in their own category. So something to keep in mind here, and is there's data suggesting that once you're in the hospital with COVID, within that hospital system, you, regardless of race and ethnicity, you kind of have the same morbidity and mortality. So say within Mount Sinai, for example, whoever's admitted kind of has the same outcomes. But something to keep in mind is the population of the US is primarily white. And what we saw was a large proportion of people of color, say Hispanic, Black, Asian, getting COVID. So despite once somebody's in the hospital, the care being the same, there's a social issue, presumably, leading to people of these races and ethnicities getting COVID more frequently. And so there are more people in these categories that have died than should based on population, or people that got sick based on population, etc. So the presumptions are, it might be that people in these populations, maybe they had different jobs or different living or social situations where they were more likely to get sick. And there's, at least in the United States, history of this we won't necessarily get into, of systemic racism or whatever you want to call it, where persons, they may be more likely to have a small apartment, not be able to social distance. Maybe they're work at restaurants, so they had to come into work, or different things where they weren't able to take time off work and be home. And so something to keep in mind. And basically what I'm saying is people that are socioeconomically disadvantaged may be at higher risk of COVID. You know, how are you're supposed to wash your hands, wear a mask, stay socially distanced. How can you do that if you live in an apartment with 6 people, that's 1 bedroom, you don't have running water, or you have very limited soap? What are you supposed to do? And so there are real societal implications here, and something to keep in mind. Now, this slide shows the days spent in the hospital prior to transfer to acute rehab. So basically, how long are these people in the hospital? Part of that time is presumably bed rest. So we see a wide range, 8 to 66, but the mean and median in the 40s, and the standard deviation kind of around that. So several weeks, most people were in the hospital, several weeks before they came to acute rehab. So very debilitated, very sick patient population that we were dealing with. The length of stay in acute rehab, you see here, 2 to 3 weeks. We had, somebody stay a particularly short amount of time. We'll get into, the reasons why that might be. People stay longer, but on average, a couple weeks, and they did pretty well, which we'll talk about. So one thing to think about, and we were very aggressive with the patients that we took, but we had a 20% transfer rate to acute rehab, or back to the acute hospital. So 20% for 5 of these 20 patients went back to the acute hospital. 2 of them died. One of them actually did well enough that they discharged home from the hospital, and 2 returned to rehab, and then they did well. And you can see the causes listed there of why they transferred out. So things to think about, even in this post-COVID population, people still at high risk of getting sick or developing other illnesses. So just some things to keep in mind. I think those numbers for us are better now, but there's a high transfer rate back. So I want to talk a little bit about the kind of functional outcomes, and we're using something, we're using a care tool, different client, but I want to kind of everyone to understand the lingo I'm using when I talk about the change in scores. So along that right side of the screen, you see in the orange, 1, 2, 3, 4, 5, 6. So that's not too dissimilar from a FIM score, let's say, from dependent to independent. And you can see what the definitions there are of how you get from one to the other, one level to the other. If you start at 6, if you're doing that, if not, you make your way down. So these are the scores that are given, and these scores are given in different categories. So this is a self-care assessment, and we call it each one is called a GG score. And so you see self-care is made up of, the self-care is made up of multiple categories here, 1, 2, 3, 4, 5, 6, 7, 8. And so we talk about kind of maybe the max scores you could get, 8 times 6 would kind of be the max, because 6 is the highest score you can get here. So we want to kind of take a look and see where people have gone to. So what I want to show you all is the change. So when we're looking at the self-care GG, people changed on average 14 points. And that's about 2 points per ADL. And when we're talking about ADL, that's these things. And then when we're talking about points, that's these. So if you start at dependent, you end up at mod assist. You start at mod assist, you leave at setup. You start at supervision, you leave at independent. So pretty much people got 2 points per ADL. For the most part, people weren't coming to us as dependent, or they wouldn't have qualified for acute rehab. So for the most part, people were able to, assuming they didn't get sick, discharge home. And if you remember the slide from a few slides ago, most of our patients discharged home, the vast majority. And we had a couple that went to another facility or back to acute care. So this is something, positive that these patients responded well to OT and changes in ADLs. And these are the PT. So again, we got A through P, and max can be 6. And we see again the change in motor score, about 35 points. And again, this averages out to about 2 points per mobility task. So again, you're going from, say, dependent to mod assist, or mod assist to setup, or supervision to independent. So big jumps in physical functional tasks also that we saw. So we were happy with that. So despite all the things we've kind of been talking about, these patients responded really well to acute rehab. I just want to take a minute or two to talk about kind of wellness and mental health, and something that I think is important to touch on, just given the high stress environment that can happen on inpatient or outpatient with dealing with patients that have COVID. So there should be constant communication from leadership. Whoever the leader of that department is or section should be communicating constantly. What's our COVID plan? How many people with COVID have we admitted, or are we going to admit, or what's happening? Giving the plan real time and saying, you know what, we're going to figure out what, over the next few days, this next thing or that thing is perfectly fine. People just want to be informed. So if you can inform them, then they feel some sense that they understand what's going on. One of the biggest things that in a pandemic like this is the uncertainty. Is there going to be enough PPE? Am I going to get infected? Is the job going to ask me to do X, Y, Z tomorrow that they didn't today? So getting everyone involved is super important. Being flexible is important. You might plan this week to say, we're going to take COVID patients, active COVID patients. And then you get feedback from your staff and they all say, no, we can't. So then you can be flexible. You don't need to be rigid. Maybe then you pivot and you say, you know what? Thanks to all your feedback, we've changed course. We're only going to accept post-COVID patients now, XYZ, just to use an example. Leverage technology, remote monitoring, video visits, anything like that you can do would be good. We have a remote monitoring program here where if somebody is suspected or has COVID, but is not at that time sick enough to be admitted to the hospital, we check in with them daily via video visit and remote monitoring. And should their symptoms change, they're asked to come into the hospital. And also video visits with doctors, with therapists, and patients with their families to keep your patients motivated. Say you're not allowing visitors at all or only during certain hours. Maybe allow, leveraging iPhones or iPads or different things like that to allow families to have visits with their loved ones. All these things are important. Physical health of your staff. So education on PPE is super important. People worry about getting sick themselves and also about infecting their loved ones. So there should be education, a lot of education, and a lot of resources on how to properly don and doff PPE. In the mornings, you should have a screener for your staff. And we have this, we have a little app. We log in, and every day we have to answer every question if we've ever had one of these symptoms or whatever. This can be done through technology in the same way, or maybe just through a checklist that's submitted and during the day, or some other way. But basically, if you want your employees not to have any of those things listed, any symptoms listed, and if they do, then they shouldn't come into work. And you should monitor them. They may need quarantine or they may need a COVID test. Usually, if you work in a hospital system, you'll have some kind of guidance from employee health or similar as to how long that person should stay out. You might have some staff that are immunocompromised, and so they would be at really high risk of being very ill if they contracted COVID. And so you can reassign them if possible. Perhaps they can do video visits. Perhaps they can do administrative work, research, educational work, but you can reassign them so that they have the most minimal exposure. Emotional health, providing support groups, education, show appreciation, even if you're having, say, weekly meetings, just thanking everyone for their help. You may not have the resources to show appreciation in another way, but words count, and people appreciate being appreciated, and the only way they know that is if you tell them. Offering childcare was something that came up here for families with children, with medical workers that were at work, doing laundry, cooking, getting home after a 13-hour day, I don't want to cook. We're still providing food or ways to get people food at home, recharge rooms or areas where someone can go and relax, maybe get a snack, just take their mind off everything, a few minutes, gather themselves and be able to go back into work. So these are all things we found to be quite helpful. And so I want to thank everyone for your time and for the invitation. I'll be happy to answer any questions that anybody has. Thank you very much.
Thank you, Dr. Escalon. I believe Dr. Escalon is with us already. Thank you again for this wonderful presentation. I know there's a small delay between the Zoom, which we're on, and the YouTube, where the talk just happened. What I'm going to do is, at this point, we don't have any active questions. Hello. At this point, we don't have any active questions, so I'm going to go ahead and start asking some questions. And I know your time is limited, so we truly appreciate you taking your time. So what I'll do is, if there are more questions after after the 5-minute period that we have, we will note them down and we'll send it to you. Perhaps you can answer at a later time and we'll respond to the viewers. So some of the questions that I had was, I know we started using the, you had mentioned about the GG scores. We just started using them recently as CMS requirement. I just wanted to get your take on how you feel the score, and it's not related to COVID per se, how that has been different, or you feel that it's better. What is your take on GG as opposed to what we used in the past, which was the FIM score?
Yeah, I don't know that it's too different, except that the documentation is a little different. I mean, it's very similar to the FIM score, and it's just a matter of different documentation. So my day-to-day is no different. So when we do like a weekly patient care evaluation conference, we speak in FIM for the most part, and we talk about where someone is functionally and what they're doing. So we don't say that the patient is at a 4. We say they're, moderate assist, whatever. So it's not changed my day-to-day. I think most of that's changed more on the administrative side when we report our outcomes to CMS or whatever. So there are other people that kind of deal with the translation of the scores. Luckily, it's not me.
Got it. So I just wanted to present it just because I don't think GG is being used in India. FIM is something that is being used, so just wanted to put it out there. The next question I have is on post-COVID fatigue. I've noticed people have been talking about it. I'm sure you've observed and have people talk about it as well. They have this myalgia, tiredness. Even after mild illness, they have been experiencing this. What is your take on that? And yeah, basically, what is your take on that? And what do you think is the cause, and what could be done?
Yeah, I think it's real. I think it's most apparent in people with mild disease, because people that we talk about with severe disease or that come through acute rehab are debilitated, and nobody thinks, oh my gosh, they're fatigued. They say, oh, that makes sense. They're fatigued. And you treat them like you would anyone else that's been in the hospital for 3 months, basically. But people that have had mild disease say, I didn't even get admitted to the hospital, but now all of a sudden at work, I can't get through a work day. I'm nauseous, I'm dizzy, or whatever else. So it exists. So we treat them with therapy and, actually some like dysautonomic therapy and even some vestibular stuff a little bit. That seems to be working okay. We have a special clinic. It's actually run by some therapist and one of our physiatrists, Dr. McCarthy. So if you're interested, I could put you in touch with her, because she mostly would see these patients that are more mild, and then I would mostly see patients that are more severe. So she may have a more thorough answer for you than I.
Got it. But I think that's happening even in the moderate and severe patients as well, right?
Yeah, it is. You're right. But it's just, it's not as surprising there. So I think it's akin to all the literature that we have for like post-intensive care syndrome, or whatever, or critical illness myopathy, polyneuropathy. You can kind of treat it the same. But for these patients that are mild, it's surprising. And I think they're more likely to be ignored. So they're people we have to have a higher index of suspicion for. And you don't just say, oh, you're acting crazy. You know, you have to take them seriously.
Got it. I think we may have, I may just ask this one last question, which is by an audience. Post-COVID recovery for athletes and football players. Is there a separate program? I think that's what they're trying to get at. Anything that's separate that they need to follow?
That's a good question. I'm dealing mostly with, again, the people that are acutely. I think if you're speaking about a professional athlete, it's a little different. You know, they're already in high peak condition. They are being tested usually like 2-3 times a week. And they tend to have more mild symptoms. So then what you would look out for are the things that we just kind of spoke about. If they're getting this fatigue and kind of prolonged symptomatology, then they would need to go to therapy, and I wouldn't return them to play until they were kind of ready, like kind of go through a progression, you know, kind of like you might do with a concussion. You say, can you handle running sprints? No. Okay, so we'll try it again in a day or two, because what you don't want is them to be injured, especially if you're talking about somebody that's a high-level athlete, because then, as opposed to sitting out a week or two, you might miss the whole season.
Right. And also, if it's a close contact sport, then that's a different issue as well. How do we, yeah. With that being said, I think that's all the time that we have. Dr. Escalon is busy. So what we'll do is we will take questions from you, but please contact the email that's on the invitation or the phone number that's on the invitation. You can either shoot a text or an email, ask your questions. We will post it to Dr. Escalon and we'll get back to you. Again, thank you very much. We truly appreciate you.
Sure thing. Thank you.
Thank you. And thank you, audience, for your participation. And we apologize for this confusion with the technological issues.
Thanks, everyone. Bye.